Welcome to Women in Surgery, where we highlight some of the very best surgeons at Houston Methodist. All of them just happen to be women. And today we have a very special guest, Dr. Rose Khavari. She is the Ben and Wendy Moreland Chair of Urology, and she is a professor of urology. Welcome.
Thank you. Thank you so much for having me.
First question that I ask everybody that is a guest here is, how did you become who you are today?
Thank you, Dr. Schaal, for having me. I was actually pretty excited about this interview, and I had been listening to some of your podcasts, but then I got the list of the individuals you've interviewed, and it got me even more excited about our visit today. So I listened to some of your interviews with surgeons at Houston Methodist and in the city, and these are people I know, I interact with, but I never knew their story and how they got here. So that opening question was pretty exciting for all those interviews. So thank you for asking that. So surgery. My medical school was at UTMB, University of Texas Medical Branch in Galveston, Texas. And during my third year, we're going through the rotations. We're making a list of what we think we want to do or not. And to be honest with you, my list was very long. I tell this to medical students, is that it's really hard to pick out what you want to do, because it's hard to know exactly what you're going to do and be happy with 20, 30 years down the road. So I had a long list. Even in that list,
What was in the list?
Honestly, psychiatry was on the list. I loved psychiatry. They were doing ECTs, which is this electroconvulsive therapy for depression, and I thought that was cool. Nephrology. Oh my God, I thought they were like the smartest people on earth. So nephrology was on the list. General surgery, ortho, ENT, so I started ruling specialties out. I think rheumatology was the first ones I ruled out. But other than that,
So how did you know that you're going to be a surgeon? Why did you pick surgery? I mean, I understand you had many surgeries on your list, but why surgery?
I think the excitement that I got from being around surgeons, being in the operating room, we had a trauma service, being the trauma bay, and to be honest with you, being in the operating room, I feel like it's so sacred. It's the best place you can be. It's the safest place you can be. Everything is so controlled. Everything is so organized, and I just love it. I think it's literally the safest place it can be. Scrubbing in,
happy place.
It's my happy place. It's my safe place. Also, not just happy. A lot of times, even you want to have boring surgeries. You want everything to be like very, very methodical and very boring. That's completely okay. It's a very safe place. You can trust it, and I like it. Just scrubbing in before any case, thinking about the patient, thinking about the steps of the case. It gets me excited every day.
Fantastic. But why urology? How did you end up in urology?
So I thought surgery. Then among surgery choices, orthopedics was what stood out to me, because not necessarily the joints, but hand surgery. I really thought I could do hand surgery. I loved the anatomy. It was very structured, very beautiful, very meticulous surgeries. So I applied. I did a lot of rotations in it. I applied for my away rotations, and beginning of fourth year, I had to do some other elective, and my school said, you can't repeat ortho again. You should pick something else. And at that point, the only thing that was left available was urology. I guess nobody was thinking about it. But I was lucky that I did urology for 2 weeks, and it got me hooked. The people in it were really fun, happy surgeons. The patients were very appreciative of the care they were receiving, because they could see the change and difference quickly. They had prostate cancer, a day later they didn't have prostate cancer. They had kidney stone, a few hours later they didn't have kidney stone. So it was very gratifying to see.
So tell me about, you told me before about the story, your first surgery that you saw, how they remove a stone. So tell us again so that our listeners can enjoy it as well. It was a wonderful story.
So one of the first cases I scrubbed in was a stone surgery. So we, as urologists, we take care of a lot of kidney stones, bladder stones, kidney stones, per se. And back in the day, it was very difficult to get rid of stones. Now we have amazing tools called ureteroscopes, tiny little cameras, 6 French, 7 French scopes, that we can pass through the urethra, the PT, the bladder, the opening of the ureter, which is very small as well, dilated, and then safely go all the way up in the kidney, look at the entire kidney, and then buzz the stone, burst the stones. We have many different tools now. We have different kind of lasers that we can use, and you can see it in real life, like playing the video game. Here's this guy, like with a little laser, and then you dust the stone and grab a little fragment if you want with a little basket. Then you come out and you go back and fish another piece, and you come out, or you dust it out and let it all pass. And I was hooked. That surgery, seeing the people, seeing how much of a difference small surgery like that can make in patients' pain. I loved it. I went back. I talked to our counselor and said, you know what, change of plans. I'm not doing ortho. I think I'm doing urology. So let's pull all those applications back. Actually, I had applied for Southwestern to do my ortho rotation. So I called them up and said, so sorry, can I just apply for a different department?
So where did you end up? Where did you do your residency?
So residency was at Baylor. So I did my way at Southwestern, and then I matched with Baylor urology. And that's actually another interesting story, because you know how match in our life, it's so, it's like a pivotal day. We want to match, such a big deal. Everything has been built up to that day. It was the same with our match. So we're all excited. My parents and I were like behind the monitor, looking it up. Okay, it's 8:00. Okay, let's log in. It's going to be there. Okay, I matched with Baylor. Yay, great. Few days later, they announced that there was an issue with the match.
Oh, no.
Forget about the match. We're going to redo the match.
Really?
So they redid the match.
Oh, my God.
I matched with Baylor again.
Okay, good.
Yes.
Some people didn't.
Some people did.
Oh, wow. Okay.
Either the location changed or they just didn't.
So how long is a urology residency?
It used to be 6 years. So almost all of them were 6 years. And when I did mine, it was half and half in 2005. 1 year of complete general surgery. We were on board with general surgery. And then 5 years of urology. And I did 1 year of research as well. Nowadays,
During residency?
During residency, my 4th year was research.
So it's an extra year you did?
It's not an extra. It was built in part of our curriculum. We did have clinical responsibility. It wasn't 100% research. But nowadays, majority of the programs are 5 years, and everybody onboards with urology, and they only spend 6 months in general surgery, and the rest is all urology. So it's much shorter. Majority of the programs are 5 years. There's a few that are research focused that they have a 6 year, but the majority are 5 years.
Yes, and what do you remember from that general surgery year that you had? I mean, this is...
So you're so far away from what you plan to do. Let's say, like, you do your rotations in urology. Ours is an early match. You match in January, February, urology, yay. Then you do electives. Then it's like you don't see or talk to urology for like a good year and a half.
Wow.
So imagine you're like spending nights being up and awake, running up and down the stairs at your county hospital, Bentab, in the middle of the night, taking care of ER patients, and you're like miserable, and you're like, what was I going to do exactly?
So they changed that for that reason? This is why it was changed? That was the sentiment that you don't really need to spend that time in general surgery. You should start with urology and continue with your...
I say that, but my best memorable times were also in the same ER at Bentab. So amazing training that I received during my general surgery. I thought it was instrumental to where I am. I do a lot of bowel work. So that strong foundation in general surgery was very helpful. We had really strong training back then. The SICs were all open, so you would take care of your own patients. As urologists, we would take care of our own patients. So we learned how to take care of critical patients. Now things have changed. I think the way things are now, people want to do more fellowship maybe, or go to practice earlier. So that 6 year was maybe a little excessive. But I loved that 1 year of general surgery. I would do it all over again.
So you developed in your career, and then actually you founded a residency program yourself. So tell us about that.
So that's something that I feel like is sort of my legacy. I'm very proud of it. I'm a surgeon, take care of patients. That brings in the different kind of satisfaction and fulfillment. But founding a residency program, training and graduating a resident, it's a completely different thing. So that's something that I'm very proud of.
So when was that? How did that come about?
So Houston Methodist is actually a very special place in my heart, because this is where I did majority of my surgeries as a resident with Baylor. This was our hub. This was our main hospital, our Mecca hospital that we did a lot of our surgeries. When I became a faculty here, and Tim Boone was our chair, we were still getting residents from Baylor, and we're still training them. We're their volunteer adjunct faculty. And my memory and my vision of my program director, who's the chair now, Dr. Coburn, was always, it's unachievable. Like, this is something that you can't do. It's like so important, and it's like so difficult to do. So when Tim approached me and said, Rose, we're going to have a residency program and you're going to put it together and you're going to be the program director, I was like, absolutely not. I don't think I can do it. You got to find somebody else that
So
can
why
do
do
it.
you think he went to you?
He's my mentor. He's a little biased, I have to say. He's my mentor. I did his fellowship. So from the very beginning, I think during my PGY2, I spent some time in his clinic. And I said, when I grow up, I want to be like Tim Boone. So, and he just took me under his wings. He helped me with my research career and then hired me after my fellowship. So I think he saw it in me that I could put it together, that I could.
So you didn't even see it
I
yourself?
did not. I thought this was not possible. And he convinced one of my other mentors, Dr. Brian Moss. So Brian actually took me out for some wine and cheese, and he convinced me that I can do it. He's like, you're doing it.
So how hard was it to put a residency program together?
I would say maybe at another institution would be harder, but here I had the support. Being in a little bit of a smaller institution, Tim knew everybody at the GME office and in the RRC. Literally, we sat down, he picked up the phone, called people in the RRC and said, we're putting together a program. What does Rose need to know or do? Who does she need to communicate with? Rose, communicate with this person. We got the head of the GME office in the room. We chatted with them. They're like, you got to fill out these paperworks. And it was very nicely, like a lot of help around me.
And when was that? What year was that?
That was in 2016.
2016. So now we are 10 years, a decade after that. How has this residency program evolved from the time that you established it till today?
So a lot. And that the residents know that I think change is one of the things that I love. And I constantly go back and forth and ask them for their feedback, and it's changed a lot. At the beginning, I think putting the program together, I borrowed a lot of concepts from my own residency. This is how the conferences need to be. This is how the visiting professorship needs to be, because that's the only thing I saw. But then we started collaborating. We started bringing in our colleagues from UT Houston pediatric side to be our partners. We have a great partnership with the Metro Urology, private urology, which is amazing, provides so much education for our residents. We started communicating with the Division of Urology at UT for other conferences. So over time, just making sure that we use every resource that we have in the Texas Medical Center and beyond has really enriched our program. I always thought that why should we even have a Baylor, why should we have Baylor Urology, Methodist Urology, UT Urology? Why not TMC Urology? Why all of us?
Is that the vision for the future?
I don't know. That's my
Maybe.
I don't know. Maybe maybe it would be difficult with all the regulatory, but why not have more shared resources?
Mm-hmm.
Create more electives that the residents that matches with Methodist, but has an interest in this specific thing that it's only offered at MD Anderson. Why couldn't that person go rotate at MD Anderson, or vice versa?
Yeah.
Or at Baylor, we have a strong neurogenic women, female urology. Why couldn't they come and rotate with us? Or same with us. Why can't our resident go do trauma at Bentop? So hopefully there will be a platform that we can use more of these resources around the Texas Medical Center and even beyond.
And you are a surgeon scientist. And so before you tell us about that part of your career, I just am curious if in your residency program there is a mandatory or emphasis on exposing surgeons to research.
So I think surgeons, especially when we start general surgery or our surgery residency, we have it in us to do research. We have that inquisitive mind that we want to know more, we want to read more. So the curriculum that we have here actually is not necessarily you have to do research, but there is definitely built-in time with protection that the residents need to do research. And it's not just going to the lab or doing this specific kind of research. They can come up with their own projects and come and present it to the group. We actually have a pretty strong research program. And the goal is not this number of publications or this number of abstracts. The goal is, what skill set did you learn? Did you learn how to like critique and read and analyze and understand a manuscript? What if you become a reviewer? How are you going to review that? Are you going to be able to use that in your practice or not? What skill sets are you learning during your research years? And you asked about changes. A couple of years ago, we were doing that, allowing residents to go do a little bit of electives here and there, but it wasn't really structured, and it was not part of our program. A few years ago, a couple of residents came and said, it's really difficult to have clinical responsibilities and do research. We want a month of research. And I said, well, what if we call it professional development? You can go and do, just as long as you present it to us and it's approved and the educational committee thinks it's reasonable and it's going to really enhance your education, we would approve it. You can do 1 month, whatever that is. So that became part of the curriculum. Now the fourth years get one whole dedicated month that they can do within reasons. Research, professional development, work on any degrees, anything they want that makes sense. Yeah. Education, they can go get educational workshops, and if they want to be educators, those sort of things.
Month.
Yeah.
That's fantastic and unique.
Well, they have 6 months, but that 1 month is like 100%.
Fantastic. Yeah. Okay. Well, tell us how you became a surgeon scientist. There are not many surgeon scientists, and I know that you're a real one and a real clinician scientist, surgeon scientist. How did you become that?
So, that's another topic that I talk to a lot of the junior faculty, is that I'm a late bloomer. During my 1 year of research, I worked with one of the best researchers in our field, Dr. Dory Lamb. She was one of the highest NIH-funded researchers.
This was during your residency.
At Baylor. But I didn't get much out of that my year because I didn't know what I wanted to do with my life. So I really didn't. I did a little bit of research, but I didn't really utilize the resources that I had until I finished residency and then did a year of fellowship with Tim. And Sophie Fletcher was another faculty that was here, and she had a K-12 grant with Dory Lamb. So it was a Baylor Methodist. Dory was her mentor. This is as you know, this is a mentored grant through the institution. So Sophie left, and Tim Boone, being Tim Boone, came by and said, "You're doing this." I have no idea. What is K mean? Like, what does that mean even? He's like, "No, you're doing this. Just work on it. You're doing this." And so he got me involved with the K. So I applied for the K with Dory and got the K-12. And the bug started moving, and I saw the light, and I just, that was the beginning of what I saw research could do, or
what is your research about?
I'm very passionate about my research. It has different aspects. So the clinical side works on the reconstructive surgeries we do for neurogenic bladder, like bladder augmentation or reconstruction, or pelvic organ prolapse or pelvic floor reconstructive surgeries, incontinence for men or women.
So this is clinical research, meaning what? Meaning
we have joint prospective databases with patients going into the registries. We look at their outcomes. We actually have the largest transitional urology database in Texas. That's individuals with spina bifida who have become adults now, and they have neurogenic bladder. So they really don't have very many places to go. There's not that many urologists to take care of them. So we have a big database on that. We take care of all their urological pelvic floor needs. So that's my clinical sort of research. I do translational research, and that is neuro-urology. I call it neuro-urology. So brain and spinal cord control over the bladder. This field did not even exist until late 1990s, early 2000s. So that's when the fMRI came around, functional MRI. So imagine when you snap your finger or move your arm, there's that motor cortex. Remember the little homunculus guy with the butt sticking out and the legs going? So the hand was over here. So that part will light up. We'll use more oxygen.
Yes.
So that shows differently on the MRI, in the functional MRI. We'll paint it red. So you can see, and then another part goes blue. It's like deactivated. This is easy. One decision, one finger, few muscles. But bladder control and bladder emptying is extremely complex.
How complex?
Very complex. Many networks, because Up to this point, majority of the research comes from animals. Well, animals, like you would do, or lesions, like we would cut lesions in the spinal cord, or we would create a lesion in the brain, or patients with strokes or tumors. But that's not humans. We're not animals. We have to be in the right place, have the right bladder volume, not be worried about somebody chasing us before we can urinate. So, and the whole frequency, urgency, getting up at night, these are completely, I think majority of them are very human specific problems. So before that, all our data was from animal models or from lesions or stroke or those sort of things, which is great. It built a foundation. We knew where to look. But then with the advent of neuroimaging, functional neuroimaging, so PET CTs and then later on fMRI,
So
the field
you're
was
doing this research here at
correct.
Houston Methodist. So you
We
have a
correct.
functional MRI, and who are the candidates? Patients?
So we've looked at brain control in healthy individuals. That was my K12. And then we started looking at patients with overactive bladder, specifically patients with multiple sclerosis and overactive bladder. So the way we would do it is we would have little wires. So we actually have the fMRI in the research, the core in the research institute. They specifically designed it for our studies. There's a little hole in the wall that we can pass our tubing to fill the bladder and have a catheter to measure the bladder pressure. So we have all these wires and little tubing
But
going.
this is in humans.
In human, yeah.
Wow.
So we would fill the bladder while they're in the scanner.
Wow.
And we would ask them to hold and squeeze and relax while we're scanning their brain. We're scanning their brain and we're filling the bladder. And then when it's full, we say, okay, go ahead and go, which is really difficult to go ahead and go, lying flat in a scanner. Very difficult. We would repeat it multiple times and then look at their brain. We actually have the largest cohort of MS patients nationally, internationally, that we've looked at their brain activity.
Interesting. And is it used to develop new medications, new devices to help people?
Perfect question. Up to this point, we were looking at identifying networks, and we have identified networks. That's why we know so much about how complex it is. There's almost 20 different regions of interest in the brain that are activated or deactivated when we're full or when we're about to empty. Great. So now we learn all of this. Then what? We're still learning, but we've learned some. Some of them are really deep in the brainstem, in the pons, which controls our breathing, controls our circulation. We can't interfere. But what if we could modulate at the region that's like accessible to us, non-invasively, or maybe invasively, depending on the disease that we're treating, to modulate or restore some of these functions if they're abnormal.
So that's the direction.
That's my R01.
Oh,
That's we started 3 years
so
ago.
You know what actually is very curious to me is that you're a surgeon. You said to me that OR is your safe place, your happy place, but actually your research is brain research.
It is brain research, but I have a lot. I have a lot of smart people around me, and I'm learning every day. So I'm interested. Patients come to me with their bladder problem, but it goes beyond that. Can we look beyond the bladder and not be so much focused on just giving catheters to the patients or pills that focus on the bladder, just anticholinergics, over anticholinergics? Maybe there's something beyond that. And so that's why we started to look at the nerves. Now we do transcranial magnetic stimulation for MS patients with overactive bladder. My colleague and partner, Dr. Hai, actually is doing it for overactive bladder, idiopathic with no MS or anything. So just opening up avenues of things beyond what our comfort zone is.
Amazing.
I think it's pretty exciting. And that's how our field can move forward. As surgeons, we won't move forward if we won't collaborate, if we won't bring in a team of scientists to help us with our question. We have such a limited vision and view. It's just that little uroscope with a little laser. That's all we can see. But I think when we bring in other collaborators, physicists, in my case, neuroscientists, neurologists, PM&R, rehab doctors, patients themselves, it's like they ask these questions like, yeah, you're right. Why not? I never thought about it. Why not?
So you told me, I think in this conversation alone, you mentioned the word collaborate, multiple times. And you told me that this is your best advice for young people who may be watching us now. So talk a little bit about collaboration. What does that word mean? What is that mindset of collaboration? What does it take from you to collaborate?
I think this is probably one of the things that my mentors saw in me is that they have no issues with reaching out, asking questions, asking for help. and collaborating, whether being on the residency side, as I mentioned, expanding to different sites, expanding to different resources that we have. We actually created a program called CURES, Collaborative Urological Research Symposium, 4 years ago. This year, we had over 150 attendees. And this is just a day for residents and students and trainees to shine in the Texas Medical Center. We invite Texas A&M, Baylor, UT, MD Anderson, and UTMB. And we all get together for a day and we just showcase every year, the first Wednesday in August. We showcase the trainees' work. And it's been amazing. Like we grew from 20 to like 120 over 4 years. So I think bringing in resources, seeing what everyone else has, how can we talk to them about our needs and share? It's amazing on the education training side, but also on the research side. I have partners, collaborators at TIER. I have partners at University of Houston, at Rice, beyond Houston Methodist. It's tremendous when you can allow other people give you feedback about your research and add to it or become your partner to do the research. It's because us by ourselves, especially if we're doing translational research, it's really hard to know everything as much as we want to know. But when you bring in smart people who are as passionate as you are, then you can do
Amazing. You're very inspiring. I also know that you're a leader. You know, we have heard part of your story, but did you invest in actually learning to be a leader? Did you ever, take a leadership development program, anything like that?
Thank you for the compliment. Yes. So I think up to this point, all these leadership roles that I've had, they came by just being on the job, just learning a lot of errors. A lot of mistakes were made, a lot of things I've learned not to do or how to do it better the second time around. But I thought that actually where I was about 2 years ago, I needed more structure. Like that wasn't enough. That just let's try different things and do it on my own. It wasn't enough. Or the people that were around me, it just wasn't enough. I needed more structured understanding, especially in a healthcare system now. It's very different than when I started almost 20 years ago. That's when I started medical school and residency. Things are different. There's a lot more moving pieces. There's a lot of things that I don't understand, especially on the administrative side, on the management side, and I would benefit from a more formal training. That's when I came across the program that you guys are involved with and put it together. Thank you. So it's the Houston Methodist Physician Leadership Program with Rice Business School. It's a good enough, short enough investment, 6 months, 2 days every couple of weeks, that I could invest in it to see what it is instead of doing a full MBA or anything like that, because that may not be the path that I may want to do. And why would do all that effort?
So what did you learn in that program?
I learned that I didn't know a lot of things.
That's good. And what do you think is the biggest gap? I mean, you're so accomplished, physician scientist, mentoring and teaching the next generation of urologists, and then you're coming to a leadership development program. Really, what was the gap? What didn't you know?
What was nice about this program, I think, is that you guys emphasize that people that come in it have already been in practice for a little bit. They're not right out of school. And also there's a plan in place for them to do leadership now, or have a role or be a director or start a program or something. They can then think about what parts of that training they can take and use it on a daily basis for their program, their clinic, or whatever that is. I think that was really, really nice because you could go back and forth. I liked it because it was very applicable. Into every course or every block was around a theme, and that theme tied into Houston Methodist, and I like that because you could see it every day. You could use it every day. Personally, I learned a lot. I learned that I don't know a lot of things.
What was your biggest gap? What didn't you know?
So I think the finance part was really a big deal that I didn't know much. We manage our budgets for my research lab. We have a big team, but still, it's very limited in what we do. operational part, how different teams and different groups can work together, how to really value and use the resources that you have, but get rid of things that you don't need to make it more optimal. Those classes were good. There was psychiatry, psychology,
Yes. Organizational
behavior. I had no idea.
Yeah.
That
So
was
it's very
really
interesting. It's I kind of very much identify with your entire story, actually. And I'm also a clinician scientist, also a surgeon, and also didn't know what I didn't know until I took some leadership program that actually taught me. I did a whole master's in healthcare management to just, to your point, learn what I don't know. So, thank you for doing that, and thank you for taking that.
good.
One thing that, we always like to ask, you told me that you're married to a neurosurgeon, which is, a scary thought. You are doing all these things and super successful and busy. And then you have a husband who is a neurosurgeon. And so how does this work?
So I'll answer that, but I'm going to tell you something kind of funny. So as part of being a volunteer or participant for my research projects, the fMRI ones, you get a 3D print of your brain because we do these amazing MRI scans and we can create a 3D brain.
Oh, you give it to the patient?
Yes.
Oh, that's awesome.
They can pick the color. They can say, I want purple. So it's a 3D print.
In their brain?
Their brain. Yeah.
That's amazing. Oh, so, can I come in there?
You can be a healthy volunteer and you get your own brain. So, and I've done a few of those. I've been volunteers for different fMRI studies. And so I have like different versions of my 3D printed brain. So
I wish you wanted to show us. Okay.
So I would take that to Ali, my husband. It's like, what do you think about this brain? Does this brain look really good to you? Is it an amazing? He's like, it's fine. It's
amazing
fine.
Brain. Beautiful brain.
So he's seen my brain.
Okay, good. But how does it work? I mean,
it's challenging. He is my biggest advocate and supporter, especially all those times that I was spending a lot of time putting the residency together. That was a lot of time away from home. And then for my research, I travel a lot compared to him. He actually doesn't travel as much as I do. It's really challenging. His patients are more, he does actually oncology, so glioblastoma, a lot of terminal cancers. So his surgeries are longer. His patients, I think, are a little bit more terminally ill. So it's challenging. We have 2 little kids, but we have a great support system. I tell, you got to do what you got to do. My parents are here. I used to have 2 nannies. I only have 1. There was time I had 3 nannies.
Wow.
1 for every 8 hours. So when my son was born, my second child was born, and I was ready to come back to work, he wouldn't sleep. It was 6 weeks. I was home and I was ready to come back home and he wouldn't sleep through the night and I couldn't function during the day. So we got a night nanny. So we had somebody cover the night, somebody cover half of the day, another person cover.
So you have to be creative.
You gotta have to be creative. I mean, these are the realities of our lives, is that it's hard. It will be hard, and it is hard. You have to let go of some of the things that you thought were priority and prioritize some other things and find help.
Yes. And what's next for you? What do you aspire to be after all these achievements?
Get better.
Get better.
Every day. Every day. I think we're also learners and we should never let that go. Get better every day. I think making sure that we're writing grants, we're asking more questions, and we're making sure our lab and our team grows. Because I think the research side is it's a constant excitement for me. New discoveries are being discovered in our field, especially in the field of neuromodulation. When I mentioned it's in the past 2-3 years, it's been amazing.
Yeah.
So working more and more on the research side, learning more and more on the administrative side, on the leadership side. Education, I've always been part of it. July 1st, we have a new program director, Dr. Monica Morgan. So I could spend more time on I couldn't have 2 babies. I couldn't have research and I was like, 1 baby is going to struggle here. So it was time. Honestly, I think we did the transition about a year prior to that. We thought about it very thoughtfully with my chair, Dr. Kobashi, because there's so much that you can give and so many changes you can do within 9 years. And after that, if you're not constantly pushing yourself, it's time for someone else to take the leadership.
But you built something over a decade, and now
Absolutely.
it's a bigger
perfect time
satisfaction to hand it.
Exactly.
Fantastic.
So,
Dr. Rose Khavari, thank you so much for being here today. You're an inspiration. What a wonderful story you've shared with us today. I'm very thankful for you.
Dr. Schaal, thank you for having me, inviting me. I've actually heard your journey before, and I've also admired your path and where you are in the leadership place that you are. You're, as you mentioned, you being a surgeon scientist yourself, being a woman, having kids, making it here.
Now I have a grandkid too. Did you know that?
You mentioned that, the tiny little human being. That's amazing. Congratulations.
Very good. Thank you so much. And thank you for watching. This was another episode of Women in Surgery. I hope to see you next time.